Okay. Assalamu alaikum. Assalamu alaikum and a very good and blessed evening to all of you. On behalf of President of Pakistan Society for Immunology, Dr. Rana Muzaffar, and the Council of PSI, I welcome you all in this second session of the webinar, title of Sharing Our Experiences of COVID-19. Today is the second session, and the speakers of the session are Dr. Samreen Sarfraz, Dr. Fazal Akhtar, and Dr. Suhail Akhtar. I also extend my gratitude to Association of Molecular Pathologists of Pakistan for joining hands to organize these sessions. Now, to start this session, I pass on the mic to Dr. Sunil, who is going to introduce Dr. Samreen Sarfraz and is going to moderate this session. Dr. Sunil, over to you.
Thank you, Dr. Sabia. Thank you, everyone, for joining us for the second seminar of Pakistan Society of Immunology on COVID-19. Today, our first speaker is Dr. Samreen Sarfraz. She is a consultant infectious disease working at Indus Hospital, which is involved from the very beginning with the management of COVID, and she will talk on experience of tocilizumab in patients with COVID-19. She will share her experience with tocilizumab. Over to Dr. Samreen. If you have, if you have questions, you can ask us in chat, or you can raise your hands. We will take questions once we finish. Dr. Samreen finishes her presentation. Thank you. Over to Dr. Samreen.
Assalamu alaikum, everyone. I hope you can hear me. Dr. Sunil, can you hear me?
Yes, Samreen. Yes, we can hear you. Hopefully, all others are hearing too.
Okay, I'll just start. Just having teething problems with loading the presentation. Okay, so the topic given to me is tocilizumab and our experience with it. As you all know that COVID-19, when it struck Pakistan, we were all taken off guard. And in this SIUT and several other organizations, they had to admit all the critical patients. And then we got on to manage them. And over time, in the past 4 months, we've had quite a bit of experience. So the game plan is to give a brief overview of COVID immunology and role of tocilizumab, and then discussion on some cases, some which were successfully treated with tocilizumab, some which were non-responders, and some which exhibited partial response, and try to get some basically clarity about where to use and where not to use. So if you can see this diagram, it is very clear that the natural history of COVID is such that in the first week we have the viral replication. In the second week, the viral replication it goes down, and the host immune response it starts to increase. And the more robust the host inflammatory response, the more severe the pneumonitis which occurs. You have a mild respiratory tract illness, which is seen in mild cases, and as the severity increases, you have moderate, severe, and critical pneumonia. And an effective antiviral response is needed needed for viral clearance. And what happens naturally is that when the spike protein binds to the ACE2 receptor on pneumocytes and macrophages, the virus's endocytosis of the virus occurs. And after that, both the innate and the adaptive arms of the immunity they come into play, and the innate response is the first to occur. The PAMP protein, the PAMP molecules, they activate intracellular pattern recognition receptors on the alveolar macrophages and the pneumocytes, and you have a release of cytolytic cytokines like interferons, and natural killer cells are activated. And similarly, both the cytotoxic T cells and B cells are activated. The cytotoxic
Hello, I think there is some problem. Dr. Samreen got disconnected, I think. Just wait for a few minutes. We will get back to you. I think they are back.
Hello.
Hello, G. G. Samreen.
Yes.
Still, your voice is not clear.
You know, Pakistan, there is due to the bad weather, we had a connection problem. So,
Okay.
so we were talking about the persistent immune response which occurs when there is massive production of inflammatory cytokines in severe and critical COVID. It has been seen and reported that there are changes in lymphocytes. There's a lowering of CD4 and CD8 and NK cells in severe and fatal cases. And there is an increase in the pro-inflammatory subsets of T cells causing severe lung injury. We see that T helper 17 cells and perforin and granulysin expressing cytotoxic T cells are increased. And similarly, it has been reported that a number of pro-inflammatory cytokines are increased, including IL-6, most prominently IL-2, IL-7, IL-10, TNF, a granulocyte colony stimulating factor, and so many others. And all of these cytokines, both Th1 and Th2 specific cytokines, are increased, and they cause lung damage and damage to other organs as well. Now, this cytokine release syndrome has been compared to the secondary HLH, and Mehta and colleagues, they suggested that secondary hemophagocytic lymphohistiocytosis is actually the reason for the immune-mediated damage which occurs. And HLH is basically characterized by uncontrolled CRS and expansion of tissue macrophages and histiocytes with hemophagocytic activity. And alveolar macrophages with ACE2 receptors in COVID infection are the primary target, after which secondary HLH starts, which is characterized by hypercytokainemia, unremitting fevers, cytopenias, and hyperferritinemias. When we try to assess this in the lab, what we see, this is from our updated national guidelines, that either any of these three criteria, if it is present, we label that the patient is in CRS. Either the ferritin is more than 1000 and rising in the last 24 hours, or it is above 2000, a single value with very high oxygen demand on the patient side, or the patient has leukemia with less than 800 cells, or the lymphocyte percentage is less than 20%, or the neutrophil lymphocyte ratio is above 5, with 2 of these: the CRP above 70, LDH above 300, D-dimer above 1000, or ferritin above 700. So any of this criteria, if it is fulfilled, we say that the patient is in CRS. So when we have hyperinflammation, which is causing lung damage, immune suppression may have a beneficial role. And for that purpose, there has been a repurposing of immune modulating therapies, because and several of them are being investigated, out of which chloroquine and hydroxychloroquine is now out. There was a lot of debate initially, and we also were giving hydroxychloroquine to almost every patient who was admitted in COVID, in our COVID unit. But now we've stopped doing that, because it is becoming clearer that it is not effective at all. On the other hand, glucocorticoids, the role is being more and more defined as the days pass. The biggest evidence was the recovery trial, which showed that dexamethasone had a very beneficial effect. And similarly, tocilizumab, which targets the interleukin-6 receptor, its role is becoming more and more defined, with data emerging on its efficacy. Similarly, many other therapies are still under trial. And this is just a diagrammatic representation of what we were all discussing right now, with the different immune targets being shown in the alveolus. So tocilizumab is a recombinant humanized monoclonal antibody against the IL-6 receptor, which was widely used before for rheumatoid arthritis, and it was also approved for CRS associated with chimeric antigen receptor T-cell therapy. In COVID-19, we know that IL-6 producing CD14 and CD16 inflammatory monocytes are increased because hyperactivated Th1 cells release GM-CSF, and GM-CSF then causes an increase in inflammatory monocytes, which produce IL-6. So both IL-6 and GM-CSF are potential therapeutic targets in severe COVID. Tocilizumab is a potent inhibitor of both the soluble and bound forms of the IL-6 receptor, and it causes a downregulation of the STAT signaling pathway. So data is emerging that it is beneficial in reducing inflammation, oxygen requirement, vasopressor support, and mortality. But what the important thing to consider over here is that the severity of hyperinflammation versus viral replication status needs to be considered, because antiviral immunity is required to recover from COVID. And animal studies have shown that IL-6 is required for viral clearance as well and control of inflammation. Therefore, it might happen that blocking IL-6 could interfere with viral clearance and exacerbate lung inflammation paradoxically. The other thing which is very important is timing of immune suppression, when to basically give this therapy. And that is till yet not very defined in literature. Now, with this overview, we come to some cases which were successfully treated with tocilizumab in TIH. I've just put in 8 cases, and you can see that 5 of them are males and 3 are females. The age group ranges from 30 to 57 years, and they have significant comorbids, the most common being diabetes, uncontrolled at that. Case number 8 is interesting in the sense that it is a pregnant female with 26 weeks of pregnancy. Now, if you look at the duration of illness, most of them were in the 2nd week of illness, 7th day, 8th day, 10th day. But there are 3 cases which presented from 2nd, 3rd, and 5th day, that is the 1st week of illness. Another interesting thing, which is our Pakistani dynamics, we had a lot of patient pool at Indus. Our emergencies were clogged, our COVID unit was jam-packed full, and that's why these patients, despite being critical with moderate ARDS and viral sepsis, they were managed mostly in ER. They were managed for 6 days and 8 days in 2 cases in ER, and we were going there, and our ER was just like a ward at that time. It was as an extension of our inpatient services because we couldn't ship them out. There was no place to shift them out, and we couldn't admit them because there was no place in the unit. So this was our dynamics at that time. Now, if we look at the severity indicators in these patients, it is interesting to note that when they had presented, they were very hypoxic. Case number 7 had an oxygen saturation of 62% on room air. Now, case number 8, as you know, is the pregnant female, and for her, if you look at the PF ratio, which is the PaO2 FiO2 ratio, all of them fall in the category of moderate ARDS. So all of them were pretty sick patients when they presented. And they were given very high flow oxygen. They required CPAP or BiPAP in ER, and their chest X-ray had shown bilateral infiltrates more than 50% of the chest, all of them. And when we look at their SOFA scores, which are markers for sepsis, which is an important marker of sepsis, all of them had raised SOFA scores. The curve 65 was not correlating in many cases. Like in case number 3, you can see it is 0, although the patient was very sick and had moderate ARDS. And the Mal-Batsa score, which is a better viral pneumonia score, was raised. So these are pretty sick patients with moderate ARDS and were critical on presentation, most likely needing BiPAP and were nearing intubation on presentation. Now, the evidence of the cytokine release syndrome that we have, if you look at all 8 of them, 1 of 20.8, in all others, the TLC was pretty much in range. If we look at the NLRs, all of them had very high NLRs. Our criteria is above 5. Case number 5 has an NLR of 23. ALC also was reduced in most of them. The lymphocyte percentage was also reduced, if you can see. So all the criteria from the CBC is being fulfilled. And if we look at the CRPs, LDH, and the ferritin levels and the D-dimers, all of those are very, very high, and showing that they are all in CRS. Even the ones which had presented in the first week of illness, they were all in CRS. Now, along with that, we also do interleukin-6 levels. Now, it is very important to note that despite the fact that in case number 7, as you can see, we have a CRP of 454. The ferritin is sky high, right? And the D-dimer is also very raised. And this patient had presented with a PO2 of 62 on room air. But despite that, the interleukin-6 is not that elevated. Our cutoff is 7. And we take 3 times upper limit of normal, which is around 21 or more. And we checked it twice and it did not raise. So we did not give tocilizumab to this patient. It was given to the others. Like in case 3, the interleukin-6 was initially 4, but then on the very next day it was 80. So this was a candidate to target interleukin with interleukin-6 receptor blocker. But in case 7 and in case 8, if you see, for the pregnant female, case 8 is a pregnant female. She was on the border, and here tocilizumab is relatively contraindicated. So we were on the edge of if we need to give or not to give, because it is risk versus benefit for the baby. So in the end, we did not give, and her interleukin-6, we just treated her with steroids and oxygen and enoxaparin, and her interleukin-6 level gradually declined. But in the others, we did give. The arterial lactate is also raised in most cases, which is again a marker of sepsis. And an interesting thing, if you see, In case number 1, the TLC was 37,000, but 37.8, but the procalcitonin was not raised. So this TLC, despite a high TLC, it's not showing that the procalcitonin, which is a marker of bacterial infection or bacterial sepsis, and it's quite raised in bacterial infections, it's not raised. None of these patients had raised procalcitonin. Now, the outcomes of these patients, in the first, we gave 400 milligrams single dose in ER, and the patient slowly responded. If you see, the CRP came down from 230 to 16. Ferritin also decreased, chest X-ray improved. The PF ratio improved from 107 to 264, and the patient, after a few days of being admitted in the COVID unit, was discharged on room air. In the second case as well, we gave a single dose in ER, and the patient was discharged on 2-liter oxygen. And they had come, all of them had come on BiPAP and very high flow oxygen. In case 3 as well, a 400 milligram single dose only was given. And you see there was an improvement in chest X-ray, CRP, and the patient was discharged. In case 4, again, the patient was DC'd. Again, only a single dose of 400 milligram. Case 5 as well, single dose. Case 6, single dose. Case 7, it was not given. The reason was that the interleukin 6 was not raised, so we did not give. And we just treated with methylprednisolone and enoxaparin, and slowly the patient started to improve, and the CRP went down from 454 to 35.4, and this patient just improved on steroids, nothing else. Steroids and enoxaparin and oxygen, and nothing else. And the PF ratio also improved and was DC'd on room air. In the pregnant female, it was a relative contraindication. We weighed the risks and benefits. We read up the literature. We were probably about to give because her oxygen demand had increased from 5 liters to 10 liters. And then slowly, gradually, it came down. We were sitting tight on it. In the end, we did not give. So the chest X-ray improved and her CRP got better. And when she went home, the fetus was also alive and healthy, and she was also okay. She was also doing fine. So these are our brief success stories. And if you look, these are 2 X-rays which I randomly selected of our cases. Case 3, look at the baseline X-ray. You have florid bilateral infiltrates, and after 48 hours of tocilizumab, you can see a significant clearance in the chest X-ray. Similarly, in case 4, you have look at the right side and also the left side. Both are pretty hazy, more than 50% of the chest. And afterwards, after 48 hours, you have some clearance on the right side. So the response when tocilizumab does respond, it gives a very fast response, and you can see it in the CRP, in the oxygen level decreasing, and the chest X-ray clearance as well. But not all cases respond. Now, I've selected just 2 cases where there was no response to tocilizumab. The first is a 43 years old, very unfortunate, just 43. The other's age is higher, it's 61. Both males, both newly diagnosed diabetics. When they had come, they were saying that they don't have any comorbids, but we found that they were just borderline diabetics. The duration of illness in the first was just 6 days. His father had died 3-4 days back, and now he had come up with these symptoms. And the second case had an illness of 10 days. Oxygen saturation on presentation, now you can see the difference. Now over there, they were in 60s or 70s on presentation. Now here it is 49 and 52% on room air. And they were in severe respiratory distress, and their PF ratio is not of moderate ARDS, this is of severe ARDS in both cases. So their severity is much more than the past cases that we had discussed. If you look at the NLR in the first case, it's 8.74. The absolute lymphocyte count is not low, but it's just borderline. But the lymphocyte percentage is low, 9.9%. The second case has a higher NLR, and the ALC is also low. It's much more severe, and the lymphocyte percentage is also lower. Now look at the IL-6 levels. In the first case, the IL-6 level at baseline is just 32.83. It's not very high, it's raised, but it's not very high. as compared to his to his lung condition, his PF ratio, which was showing severe ARDS, IL-6 is not that raised. But the second case is a classic case where the interleukin 6 is enormous. I mean, it's 697.6. I think this is the highest percentage, highest number that I have seen right now. Most of our cases have an interleukin 6 level of 80, 100, 120, 697. I have not seen. I think this is the highest that we have reported. If you look at the other inflammatory markers, all of them are raised and showing pretty much the full-blown picture of cytokine storm. Both of these patients received 2 doses of tocilizumab before ventilation. We tried to save them from ventilation by giving them tocilizumab timely. In addition, the second case also received plasma, and he was also given remdesivir, though I think the remdesivir was given pretty late. It is very interesting that despite this, both of them got ventilated, and the most important thing in this slide is probably that both of them developed severe sepsis later on, bacterial sepsis with one developing Kleb bacteremia, central and peripheral lines both, the other developing VAP and Acinetobacter bacteremia, and they died of MODS and multi-organ dysfunction, refractory septic shock, were on dialysis in the end. The duration of stay of the first patient was 9 days, the other was 20 days, and they had a significant stay on the vent, both of them. Now, this is from a study which shows that interleukin 6 has a big prognostic role. If those patients who require ventilation, their interleukin 6 levels are usually above 100, above 8, mostly above 80 and 100 at baseline. And maximal IL-6 before intubation is around 100 to 200, as compared to those who do not require intubation, their IL-6 levels are lower. And so our second case is a classic case where the IL-6 level has served as a very bad prognostic marker. So if you look at this case 1, we had a partial clearance in his chest X-ray after tocilizumab, and after that we had a rebound phenomena, rebound CRS, which was seen, and we also see in the CRP that it decreased and then again increased. And similar in the second case, he did not respond at all. There is no change in his chest X-ray, and his CRP also partially declined and then again increased. Now, just 2 more slides. These are 5 cases who all presented in severe ARDS, who were given tocilizumab, some with remdesivir, and some only with tocilizumab, and all of them developed persistent inflammation. Their duration of illness at the time of their death or ventilation was 34 days, 28 days. I mean, 1 month into illness, and they were still requiring high flow oxygen. Their hospital stay was also very, very prolonged. They had no evidence of bacterial or fungal infection, and they were being treated on the lines of cryptogenic organizing pneumonia post-COVID, and 2 out of them expired. 1 is still ventilated, and 2 are slowly improving. If you look at their CT scans, they are seeing persistent ground glass inflammation even on day 30, day 28. This is case 1. You can see case 2, case 3, similar patterns. Case 5. So they had persistent inflammation, so they had a partial response which prolonged their illness, and their PCRs were positive even on day 30, day 28 of therapy with tocilizumab. So to summarize our experience, tocilizumab in our experience has saved several critical patients with mild to moderate ARDS from mechanical ventilation, resulted in improved oxygenation and good outcomes. When used in severe ARDS or with very high IL-6 levels, the prognosis has not been altered. It is best to avoid in already ventilated patients, as the risk of nosocomial infection is already high, and it increases the tendency of bacterial sepsis many folds. Ventilated critical COVID with high SOFA scores are best treated by only supportive care. In patients with CRS, the best deciding factor to gauge effectiveness of tocilizumab is IL-6 levels, because there are cases which we have seen where CRP, D-dimers, and D-dimer and ferritin are raised, but IL-6 is not raised. Do not use interleukin-6 levels post tocilizumab to monitor response, as they keep on rising and they are not of use. In our experience, even a single dose of 400 milligrams has been effective for most patients, and it is also cost effective because the vial is of 400 milligrams. A second dose should only be reserved for very severe cases in last resort, and it should be given within 12 hours. Our experience of combining IVIG and tocilizumab has not shown any benefit, and so we are not using that, and it's also not recommended in Pakistan's guidelines. When remdesivir is available, combining both remdesivir and tocilizumab, we should look at the liver functions very closely. And some do's and don'ts in tocilizumab is that it is contraindicated in TB or in zoster, in bacterial sepsis, when you have got deranged liver functions, multiple sclerosis, pregnancy, relative contraindications in ANC or less than 2,000, thrombocytopenia of less than 50. Thank you.
Thank you, Dr. Samreen, for a nice presentation and summarizing what we are doing for last 3 months. In some we are seeing response, and some, despite all our efforts, we are unable to basically establish them. There are few questions. First question is from Dr. Natasha Anwar. She's saying, is tocilizumab an experimental treatment? I think yes, it's not been still approved by anyone, but people are seeing response because people have seen response in cytokine release syndrome apart from COVID. So people are again mixed response, just like Samreen described. In few it's working, in few it's not working, despite all our, whether we give 2 doses and even full doses. Second question to Dr. Samreen, she's saying, is it a success? In which cases you describe it? Although this is not a randomized controlled trial, how can we say or determine a causal relationship?
We cannot, until we do a randomized trial, we cannot determine a causal relationship. That's true. And but in our experience, when we have used it, now we have gathered up the data and we are using historical controls and analyzing it, and probably it's going to be published. I didn't use that data over here. I just showed random cases where in some we had success and in some we did not. But on a crude analysis of the data that we have, we are still seeing that patients have benefited, those who have presented. But obviously, it's as we did not have any randomized trial, we cannot give a very robust, I mean, we cannot say that it is a causal relationship established.
Also, if we know about international published literature till now, basically, I think none of the randomized controlled trial till now has been published. There are observational trial published in which it's a single arm prospective trial from Italy who have been published, and they have seen some good response with it actually. Question from Professor.
That's our observation as well. I mean, some responses there, and but that's an observational study. I mean, from our side also, we are going to we are planning an observational study to be published soon.
Question from Professor Suhail Akhtar is that following interleukin-6 seems to be good idea, but there are other cytokines which may be pathogenic. So should we stop following CRP, LDH, etc. if IL-6 is so sensitive for cytokine storm?
What we need to consider is that cytokine storm has a multifactorial etiology, as as in the initial slides I had mentioned, that there are so many different cytokines which are raised. What has been proposed is that you should try to monitor as many cytokines as you can and target specific cytokines. Like anakinra, if IL-1 is raised, you can give the anakinra, which is the TNF alpha, TNF inhibitor. Sorry, if TNF is raised, if IL-1 is raised, you target IL-1 inhibitor. If TNF is raised, you target it with the TNF inhibitor. So this is the idea of being specific about therapy. For interleukin 6 is specific for tocilizumab. So wherever you plan to give tocilizumab, there you should monitor interleukin 6, because we have seen that CRP and LDH, they can be raised, but interleukin 6 may still not be high. However, CRP and LDH, it's good to follow them, because you do plan to use steroids when you see an evidence of CRP, LDH, ferritin getting high. So because those patients do benefit when you start dexamethasone or you start methylprednisolone early.
Yeah, can I add to this? Because, you know, in some of the cases, Sameen showed that although the CRP was very high, but interleukin 6 was low or normal. So maybe those are the cases where other cytokines like interleukin 1 or TNF alpha may have been raised. So we were not able to look at them. So think following with the CRP is essential. And then you can do other cytokines. I mean, it's easy to do interleukin 6 now, as is easily available, and it is not cost effective to do other cytokines. So yes, CRP is essential, and interleukin 6 is also essential for that. Yes, Dr. Sunil, over to you.
But problem with, I think the problem with interleukin 6 is that it's not commercially yet available in Pakistan to most of the institutes. Actually, it's some institutes which are doing it. They will. So people, I think, those who are managing, those who don't have available and they cannot do it outside their setting, they are still following clinical oxygen requirement and these inflammatory markers, of which ferritin I have a very bad experience. I have seen very high ferritins and very low ferritins. Probably it's again till the IL-6 is available commercially and to all the, probably it's again mixture of clinical oxygen requirement, how fast patients are deteriorating along with these inflammatory markers.
Yeah, I mean, Sunil, we were also doing the same thing before we had the interleukin 6 levels available with us. And then we were puzzled that some people have an excellent response and some don't. And then when we analyzed, we had their blood samples, and when we analyzed them retrospectively, we found that some people who did not have a good response, they did not have some of them did not have elevated interleukin 6 levels. They had targeted based on ferritin and CRP. And given them obviously, but tocilizumab will work when interleukin 6 is raised. It would not work when it is not raised. So this is something which I think should be more available, especially the prevalence of COVID and this criticality of our patients. And this is such an expensive drug. So to use it, and it's like a double-edged sword, right? Because you are making the patient immunocompromised and making him prone to bacterial sepsis. So when you want to give the drug, you should be very clear in your mind that it is going to work or it might work.
Over to Doctor. Thank you for joining, and now we have a second presentation. Over to Dr. Sabia.
Very excellent presentation by Dr. Sameen. Thank you very much. Now our second presenter is Professor Fazal Akhtar from SIUT. And for that presentation, I invite Professor Ejaz to do the moderation, please. Dr. Ejaz. आगे कर दो ना यहाँ से आगे कर दो यहाँ से
Can you hear us?
Yes, sir, we can hear you. Thanks so much.
All right, so I think we start. So it's my pleasant duty to introduce my colleague, Professor Fadil Akhtar, who is Professor of Nephrology at SIUT, and he has been very actively involved over last 3 months in management of renal transplant patients who have been infected with COVID-19. So let's hear about what our experience and other people's experience have been in immunosuppressed population. Can you, Dr. Sabia, can you allow us the screen sharing? It is.
He's doing it. Yes, I think you can share the screen now. You have the rights.
Thank you, Dr. Sabia, and all the organizers of the Pakistan Society of Immunology. I think my topic will be going from the basic, it is more clinical, that we are very worried that if COVID infection happens in an immunocompromised patient, and like beside malignancy, any organ transplantation is one of the examples that you get is immunocompromised patient and what happens to them. So I will start with introduction that it's the COVID started in December 2019, and by 7th of January, it was we found out the genome of the COVID, and then it was regarded as a SARS-2 COVID infection. And it has taken the world just like a cytokine storm. And it is spread everywhere. Up till now, over 14 million people have been affected. In Pakistan, over 260,000 people have been affected. And in Pakistan alone, over 2,500 people, they have died. Now there's the risk of the transmission was as it has been explained, that we all know that the ACE receptor is the primary receptor where the SARS-CoV virus acts, and it is abundant in all the organs which we transplant: the lung, kidney, liver, heart, intestine, and we are worried that if we take whether it is a live donor or whether it is a disease donor, if somebody who had a COVID infection, even in the past, are asymptomatic, what will happen that if we transplant them, that whether the disease will spread to the recipient as well. I mean, so far so good. We'll say that no donor-derived COVID infection they have been reported, and bloodborne transmission it hasn't been reported either, and we don't expect it because the stage or the length of the viremia is too short. The post-transplant risks, they are higher in any immunocompromised patient, especially the renal transplant patient, because they have got frequent exposure to the healthcare worker, and they have got chronic immunosuppression, and this chronic immunosuppression will lower the infectious dose needed to cause COVID-19. And the chronic immunosuppression will impair adequate immune control once the infection is established. And once they get infected, they will shed the great amount of the viruses, and they may shed for a longer duration as well. Not the amount, but the duration will increase. So I'll start with the clinical presentation, is just like in immunocompetent patient. And this is the study that has been published in American Journal of Transplantation. The 54%, they had very mild illness. The 21%, they had moderate illness. But what you'll notice it, that 25%, they were critically ill. And this is a very difference from the general population. In general population, we expect that 5% of the people, they will become severely ill. But in the renal transplant recipient, about 25% of them become the critically ill. And this implies very bad prognosis in those people who become critically ill, and once they get infected, that they will have very severe disease. The management of acute COVID infection is more or less same as in non-renal transplant patient. But there is some changes we want to do that. And then we want to adjust the immunosuppression. We don't know because it's a new disease, and everybody had different recipe for changing the immunosuppression. And there is a very recently a published article in the EDTA that how should I manage immunosuppression in a kidney transplant with COVID-19. And I've taken this slide from this guideline, that in asymptomatic patient who are swab positive for COVID-19, they divide them into two, whether they have got a high risk or whether they have got low risk. The definition of the high risk is that the age is over 70s, they have got comorbidity or risk factor like diabetes, cardiac disease, pulmonary disease, heavy smoker, or they are overweight, BMI over 30, or they have got impaired renal function, the GFR less than 30. Or within the last 3 to 6 months, they have lymphocyte depleting therapy. In those patients who although they are asymptomatic, then consider reducing or stopping the antiproliferative agent and mTOR inhibitor if they are on triple therapy. In the mild disease, if the patient is alert, they have got only mild respiratory or GI symptom, they are apyrexial or the temperature is less than 38 degrees centigrade, they haven't got intense cough or dyspnea, the oxygen saturation is 95%, respiratory rate is less than 25, they have no evidence of pneumonia either on the chest X-ray or the CT scan, there is no need for hospitalization. They can be easily managed at home. And what we used to do that in those patients, we used to continue their original treatment. But if the patient was on immunotherapy, triple therapy, then consider stopping the antiproliferative agent or mTOR inhibitor, but continue CNI and the steroid. If they are on dual therapy, then continue with the dual therapy. Like if they are on cyclosporin or tacrolimus and prednisolone, just continue them. But the question is that what will happen if they are on like antiproliferative agent and steroid? In these cases, I mean, there is no clear-cut guideline, but what we used to do that instead of we used to change the antiproliferative agent to consider it inhibitor. If they have got on dual therapy and they start free regime, they are on CNI plus antiproliferative agent, consider replacing antiproliferative agent with the steroid. If they are on CNI and mTOR inhibitor, then change mTOR inhibitor to low dose steroid. If they are antiproliferative agent and mTOR inhibitor, then consider changing one of them to steroid. And if there is no improvement in the first 3 to 5 days, then consider about reducing the dose of the calcineurin inhibitor. They have got evidence of mild COVID-19 pneumonia. That means the oxygen saturation is 94 to 95% of the room air. Respiratory rate is between 25 to 30. Or they have got lesion of the chest X-ray or the CT scan, then divide into 2 again. If the high-risk patient, the risk was the same, age over the 70, comorbids like diabetes, hypertension, heavy smoker, BMI over 30, EGFR less than 30, or whether they had the lymphocytic depleting antibodies in last 3 to 6 months. In those patients, if they have got mild disease, stop the antiproliferative agent and stop the mTOR inhibitor. And then not simply that, because you have to save the life first, then stop the CNI as well. And increase the steroid to 15 to 25 milligram per day. If they have a mild infection, but they're not at high risk, just simply stop the antiproliferative agent or mTOR inhibitor and maintain them on CNI and steroid. But try to maintain the CNI, cyclosporine or tacrolimus, to the lowest level which can be allowed, and continue the steroid in the maintenance dose. In more severe infection, the oxygen saturation is less than 94 at the room air. Respiratory rate is more than 30. The unstable or deteriorating condition, whether they require non-invasive ventilation or they require transfer to intensive care with intent, whether you're going to ventilate them or not, then in those cases, because it is a life-saving, you have to save the life first, then discontinue all the immunosuppressive agent and increase the dose of the steroid by 15 to 25 milligrams per day. What will happen? I mean, we always think about it, that what's going to happen if we stop all the anti-rejection treatment. Because these patients, they are very much immunosuppressed. That even with the stop all the immunosuppressive patients, that once the immunity, once they start recovering, then you can start the immunosuppressive agent slowly, and then they don't go into rejection. A patient with the higher risk of rejection, like they are under 1 year of the transplantation or they are highly immunized, then consider continuing with the low dose of CNI. And once they start improving, then consider to restart the previous immunosuppression 5 to 15 days after the symptoms have subsided. And now I would like to share the SIUT experience. We admitted approximately 135 patients during this period, but we are in the process of analyzing the data. The data which I'm going to share with you is of only 116 patients that has been analyzed so far. And in these out of 160 patients, there 105 patients that were alive and discharged. That means over 90% of the patients, they have been doing very well. And only 5%, they expired. That makes 4.3% a patient. Six of them, they are still inpatient, and 15 of them, they required the ICU admission. Among them, The comorbid was 14 of them, 14 out of 116, that make 12% of them, they were diabetic, 51% of them, they were hypertensive, and a small number of them had ischemic heart disease, chronic kidney disease, or the dialysis dependent. Incidentally, one of the renal transplant recipient, she was pregnant, but she had a mild disease, and she didn't require anything other than increase of a dose of the steroid. The symptoms, they were same as the non-immunocompromised patient. That majority of them, they presented with fever. 82% they had fever. 27% approximately had cough. 19% they had the myalgia, and 18% they had shortness of breath. I mean, it was very interesting to see that some of them, the only presenting complaint was the diarrhea. They didn't have the cough, they didn't have the myalgia, they didn't have the shortness of breath. And that is 11% of the people. The only complaint was the diarrhea. And some of them, they had the abdominal pain as well. The treatment that we gave is, beside the antibiotic, and we started antiviral. Initially, we used chloroquine in some of the patients, but it was discontinued once we knew that it doesn't work. So what you will notice that 31 patients, that means 26.7% of the patients, they need tocilizumab. What does it shows? That those patients, they were either they had moderate severity or very high severe illness. Either they have moderate illness or severe illness. And this is very different from the general population. As this is the experience same as in of the United States, that they as compared to the general population, only 5% they get the moderate or severe illness, but in the immunocompromised patient, approximately 1/4 of them, they get moderate or severe illness. We used IVIG in 1/4 of them, 25% of the people, half of them, they needed the steroid, and the anticoagulant, they were used in 32% of the patient. Now the question is that we know is the number of the cases that is decreasing, the disease is becoming less severe, and now we can see that there are empty beds in the ICU. Or in this city, at least I can tell about this city. So the question is when to start the living transplant program. Organ transplantation is essential medical service. You cannot postpone it indefinitely because it will increase the waiting list. And in Pakistan, where the mortality rate is high among the dialysis patient, I mean, I will say that I give the example that 10% of the people who are on the waiting list, they died for one or another reason. That includes some of them, they had the COVID infection as well. So what we need to know is that what is the risk of the transmission from positive donor to recipient? What will be the impact when the recipient become COVID positive, and how it will influence the transplant outcome, and what is the effective treatment once they can catch the COVID-19 infection. The COVID-19 infection aspect, it has restricted the transplant program in the epidemic area because there is a high risk of infection in the immunocompromised patient. The risk of transmission, there is a risk of transmission in the healthcare worker as well. There is impact of travel ban on the organ procurement on organization activity. And in the developing country, there is lack of medical resources. And what we need to remember that all our resources, they have been diverted to fight the COVID-19 infection. So that's the guideline. What does it shows? That think about what is the urgency of the transplantation. If there's no urgency of the transplantation, then defer it. But if there is an immediate urgency, I will just give you the example that there is no NGO access. Then in that case, it becomes urgent, and then they will have to think about doing the transplantation. And once we think about doing the transplantation, how will you screen the donor and the recipient? The donor is in the screening the donor, you need to take the history of travel, history of contact, and then you investigate by using the nasopharyngeal swab, CT scan of the chest, or chest X-ray. And then you decide what is the donor exposure assessment. Category 0, they haven't traveled to any to CDC area of the high risk area. Like give you the example, they haven't traveled to New York, or they haven't traveled to London, or they haven't traveled to Karachi. The donor has been in the area which is considered as a high risk in the last 21 days. Category 2, the donor has direct unprotected contact with someone who had a COVID-19 infection over the last 3 weeks. Category 3, the donor had direct unprotected contact with confirmed case with COVID-19 in the last 4 weeks. The donor clinical assessment, the category 0, asymptomatic, negative PCR, chest X-ray and CT scan, they are completely normal. That is category 0. Category 1, they are symptomatic, lower respiratory tract infection, fever, anosmia with negative PCR for SARC value. And the chest X-ray, they are chest X-ray or CT scan, they are completely normal. Category 2, symptomatic with negative PCR for SARS-CoV, and CT scan, and CT scan and the chest X-ray, it shows that there might be some COVID infection. And the category 3, they are symptomatic with positive PCR, and the CT scan or the chest X-ray does suggest that they have got a COVID infection. So which one to accept for the transplant program? The low risk category, the risk category is low. The exposure is 0 to 3. Clinical category is 0. That mean they have everything. The chest X-ray is normal. The CT scan is normal, and they have got a negative PCR. Then you can accept for the for transplantation. If the risk category is moderate means clinical category is that although the PCR is negative, but they might have some suggestion on the chest X-ray that they have got an infection, then that becomes the moderate category. The high category is that although they are symptomatic, they're PCR positive, then that they cannot be transplanted. In the moderate category, then you have to think about the risk and the benefit ratio. And how will assess with the transplant candidate? I'll talk about the recipient. If the patient has come from the home, that's the algorithm. Then on the admission, you take the history and do the necessary examination. If the history is negative and the CT scan is not, with the CT scan nasopharyngeal swab, it doesn't suggest COVID infection, then go ahead for the transplantation. If once you call from their home, they have some symptoms suggestive of COVID infection, and then then the transplantation is deferred. Once they are admitted, although they didn't have the signs and symptoms, once they are admitted and once they are investigated, then if there is some suggestion that they might have the COVID infection, then transplantation is deferred. Then isolate and obtain the nasopharyngeal swab. Those patients who are hospitalized, then monitor with nasopharyngeal swab and CT scan of the chest. If the nasopharyngeal swab, CT scan of the chest, then proceed for the transplantation. The swab is negative, but the CT scan of the chest suggests COVID-19 infection, then transplantation is deferred. The swab is positive, it's become very clear that transplantation is deferred. Thank you very much for listening to me. And I would welcome any comment, any question.
So what we have learned in last 20 minutes is that the immunosuppressed transplant patient is a higher proportion of them would develop more severe disease, and the core management is that with progressive worsening disease, you have to reduce the intensity of immunosuppression. The anti-proliferative agents are stopped first, and in more severe, critically ill patients, you have to stop calcineurin inhibitor. And in those cases who are really very severe, the only immunosuppression which is allowed is steroid. So this is a question from Dr. Sabiha, that in transplant recipients, there may be prone to increased infection, but lesser amount of inflammatory response. But obviously this is not the case. But I think what we have seen here is that there are a larger proportion of them in our experience as well. They required ICU care. So there were certainly more severe illness compared to other non-immunosuppressed population. I wonder if Dr. Fazal Akhtar wants to add.
What I will say, the proportion, I mean, I will say that about in the ICU, and during this epidemic, we have admitted about 150 patients. And in this one, this study contains only 15 patients, but as a whole, I remember that it is between 25 and 30 patients. They were the transplant one. So what it does, it suggests that because of the immunocompromised status, the disease is severe. And once the disease is severe, they have got more infection and more problem. So it is not that they have got, I mean, I can't say that whether they had a cytokine storm or not, because we were unable to measure the IL-6 level. But clinically, they were behaving like a cytokine storm. So it is not they think that they will have the less inflammatory response, but the inflammatory response was same as in the immunocompetent people.
So the next question. Yes, Dr. Sabia, yes, proceed please.
So So can we say that as they are more prone to have more secondary infections after getting COVID-19 infections, so they may be adding to the whole problem in these immunocompromised patients,
Yes,
albeit they are on immunosuppressive drugs.
yes, I mean, you're absolutely right. Because because they were immunosuppressed. Once they have the infection, they were more immunosuppressed, and they had more chance of having this severe infection. And what I can say from the experience is that if they had any secondary infection, it was very difficult to treat them, or it was very difficult to save them. I would say that most of the people, if they develop secondary infection, most of them they died.
Thank you.
Another question from Dr. Natasha Anwar. She's trying to know what has been the most challenging aspect of managing transplant patient at SIUT.
I mean, the most challenging aspect was at one time there were so many patients that I couldn't find any bed for them. That was the most challenging one was. That in fact the most challenging was that I have to keep for at least for the some time the COVID positive patient in COVID negative area, because there was no bed. And the other challenging infection was once they become sick, it was very difficult to manage them. Fortunately, I mean, I will say that over 90% of the people, they had either no symptoms or they had very mild symptoms. So it was easy to manage. But otherwise, the management, I mean, with the non-COVID infection, the management was the same.
Right. So I don't see any other questions. So shall we end of this session now?
Okay. Thank you, Dr. Ijaz and Dr. Fazal, for such a nice presentation and nice talk. We've learned so much about the immunosuppressive patients and the dilemma in those patients about COVID-19 infection. Now, our next speaker is Professor Sohail Akhtar. So I invite Dr. Saima Saeed to moderate this last session. Dr. Saima Saeed is a consultant pulmonologist at the Indus Hospital. So over to you, Dr. Saima.
Ji, Assalamualaikum, Dr. Sabia, and thank you for having me and pulmonology in your wonderful sessions. I'm so sorry I'm not able to turn my video on. Actually, I'm at home with no electricity because of the rain, and so I really appreciate your help in sorting out the slides at your end. So welcome everyone, and thank you for your attention this evening, because I know we've had some really interesting talks on the use of tocilizumab and looking at patients who are immunosuppressed and renal transplant patients, which are a really unique group of patients. And tocilizumab, as we've discussed, is an experimental agent. And so we're very interested in the new evidences that are coming out from that. But in fact, COVID-19 hits the lungs first and foremost, and in moderate and severe disease, we pulmonologists have seen a lot of it. So I really am pleased to be able to welcome Dr. Sohail Akhtar. He's our professor and head of department at for pulmonology at the Indus Hospital, and welcome him to share some of our experiences here at Indus and throughout the city on COVID in our particular field of interest. Over to you, Dr. Sohail.
So, Dr. Sohail, you have to say next if you want me to change the slide.
Okay, can you hear me now?
Yeah.
Acha. Thank you. Can you see my slide as well? The share screen. Is my are my slides being projected? Are my slides being projected?
Yes, Dr. Suhail.
Okay. Thank you. Thank you very much, Dr. Sabia and Pakistan Society of Immunology, to invite me. And thanks, Dr. Saima, for the introduction. And contrary to the excellent two talks that we heard, this will not be as much of a experience sharing. It will be more than of a literature sharing in pulmonology. And when Dr. Sabia asked me to give this talk, I was lost in where to start and where to end, because it's such a huge topic. And as Dr. Saima was saying, that pulmonology is the first gateway of COVID problems. And there is no end to the topic. But I have, for the simplicity, I have kind of just restricted myself to a few things, few topics, and I'll just share on them, and I'll like to finish in time, inshallah. Before we go any further, can you see the slides? Just checking.
Yes.
Right. Okay. Before we start, it's fair to say that we, despite such dearth of knowledge and thousands of researches, we know very little about COVID. We know very little about a lot of things in science, and we have to just be praying that whatever we do is for the benefit of the patient. So I'll start by a verse from Surah Al-Baqarah, Subhanaka la ilma lana illa ma 'allamtana innaka antal alimul hakim. Only it's God Allah who gives us the knowledge, the wisdom. Otherwise, we are just nothing in terms of knowledge. So I will just like to touch a few of these topics: COVID-19, its impact on immunity, pathogenesis, respiratory diseases, how they're affected by COVID. I may be only touching asthma and COPD, bit of pneumonia, and how has COVID-19 affected our respiratory practices. So we all have seen this slide many times. It's been almost 7 months in Pakistan. We've had so many cases. Just to take you back to the virus, and why I want to still show this slide despite being so old, is this ACE2 angiotensin converting enzymes receptor 2, which is quite important in pathogenesis in some respiratory diseases that I'll be talking about. We very well know that old people and those with comorbidities get more sickness with COVID-19 than healthy and young people, etc., etc. So I'll just move on to the second slide, the next slide. The way by which body counters any virus is common. With many viruses, as is with COVID-19, there is an innate immunity early, and there is an acquired, a little delayed immunity. The whole issue of what is going to happen after a viral infection is how the body handles it appropriately and timely. If in the innate immunities, the interferons and the acute cells like polymorphonucleosides and macrophages, which start their job, and in the later stages, the CD4, CD8 cells and the resultant antibodies they produce determine whether the body or the person will develop long-lasting immunity or not. So here we have seen in COVID-19 that there is a double-edged sword. Either there is a rapid interferon response resulting in rapid viral clearance. So fortunately, 80% of the patients who are affected get very little or mild disease, and then they're better. However, if there is a delayed activation of innate immunity, there can be severe pneumonia, because of the release of cytokines. There may be ARDS, septic shock, and other complications. So it is really the way by which a body responds to the viral challenge that determines which way is it going to go to. And hence, the people who cannot mount a good inflammatory response fare badly. I am definitely not even a student of immunology, I must say, but there are several diseases in which immunology plays a lot of part, and we have to know bits and pieces. So we know that the increased cytokines in serum associated with pulmonary inflammation and extensive lung damage, which was described in the two sister viruses, SARS and MERS, were also reported in the earlier study of 41 patients with COVID-19 in Wuhan. That was reported, I think, in January. There is an association with a cytokine storm mediated by high levels of pro-inflammatory cytokines, several of them interleukins and colony stimulating factor and TNF alpha. Another of the early studies from Wuhan showed, which was done in 450 patients, identified that severe cases showed significantly higher cytokines and chemokines such as tumor necrosis factor and others. So there has been early recognition of the cytokine role, as well as the identification of which one causes the pathogenesis. And we very well know that most of the patients who die of COVID-19 die of ARDS. And again, it is mediated by so many uncontrolled systemic inflammatory response by so many pro-inflammatory cytokines, which triggers a violent attack by the immune system to the body, causing multiple organ damage and death. And as we were listening to Dr. Samreen earlier, interleukin 6 has been one of the major culprits. I wouldn't say it is produced by activated leukocytes, stimulates the production of acute phase proteins, and promotes the differentiation of B lymphocytes, and plays an important role in thermoregulation and other functions. I didn't want to dwell too much on immunology as it's not my field. I'll come to respiratory diseases. There is a question mark of whether it's a healthy relationship or a bad one. Right from February, the WHO and CDC have been telling us that apart from age and several hypertension, heart disease, and others, asthma and COPD are also a risk factor for severity in COVID-19 cases and are common comorbids in these patients, apart from the ones that I've mentioned. However, several studies, several meta-analyses have shown that asthma and COPD are not as common. It has been our experience as well. The cases that we have been seeing in Karachi, hypertension and diabetes far outweighs any respiratory comorbidities. Why should we have thought about asthma? Is very natural, because the most frequent trigger of asthma exacerbation is airway infection, and it's mostly viral. So there was another new virus, and it was very natural for us to think that it will have several exacerbations of the asthmatics. And asthma is pretty common in our community, any community for that matter. And the patient's innate immune system, if it's unable to prevent the spread of these viruses, then it produces the lower respiratory tract symptoms and pneumonias. And such impairment of antiviral response suggests that patients with asthma might be at high risk. As I said, it's very natural for us to listen. However, these several meta-analyses, several studies have shown that this is not the case. Asthma is not as common in COVID-19 cases as other diseases are. For example, these 8 studies with more than 17,000 patients in China, America, and South America have shown that the comorbidity rates of COVID-19 with asthma were significantly lower than the reported prevalence of asthma in the respective region. Not only that they were less common than hypertension and diabetes, but they were also less common than the reported incidence of prevalence of asthma in the same region. However, The authors have cautioned that there are limitations to the study because they were retrospective. And as we have ourselves experienced, that there's hardly any time to go through the previous history and very accurately in a very, very sick patient presenting to us. And these are patient-reported diagnosis, and many patients actually don't know that they have asthma. So we have to take it with a pinch of salt. However, these were the findings. Then the prevalence and characterization of asthma in hospitalized and non-hospitalized patients with COVID-19. There was this report in June in Journal of Allergy and Clinical Immunology, which reviewed 1,500 patients with COVID-19. Only 14% were asthmatic, and more so, asthma was not associated with an increased risk of hospitalization and also the inhaled corticosteroids, which they were using, did not increase the risk of hospitalization. So that was a great relief, because inhaled corticosteroids, as we very well know, is a cornerstone of asthma management. However, the study did not look at a very pressing question: which asthma? Because asthma, we know, has several phenotypes. So another study published recently analyzed 500,000 people, and they came up with the conclusion that the severity of COVID-19 was more in non-allergic asthma rather than allergic cases. And the conclusion that they drew, and I think most of these conclusions can be premature. Our understanding may change with the passage of time. However, ACE2 receptors in the lungs, which act as gateway for COVID-19, and let the virus enter the lung and cause its damage. These receptors expression was found to be lower in people with high levels of allergies or allergic asthma. And hence they thought that this may be one of the reasons or the reason why allergic asthma patients do not have so severe COVID-19 cases as non-allergic asthma. Then our big question was what should we do with these asthma patients if they have COVID-19? And I'm not talking of systemic steroids, I'm talking of inhaled corticosteroids. There is a plus and minus with steroids there. They decrease the expression of ACE2 receptors, guarding the respiratory system, so in a way beneficial. But we know that if we use injudiciously steroids, they lead to a susceptibility to the virus by suppressing the body's immune response. Now, what about COPD? COPD is not only an inflammatory disease. It's we very well know it has an inflammatory and cytotoxic component going together because of the inhaled toxins. Again, this almost similar inferences were drawn that prevalence was found to be much lower than initially predicted in COVID-19 patients. These are 4 studies which are in front of you. In China, 1,500 hospitalized patients had virtually very little COPD patients as comorbidities. In another Asian studies, the COPD incidence in hospitalized patients was less than 1% as compared to hypertension and others. In Italy, there was 4% in prevalence of COPD. In New York, it was 5.1%. And as you can see, hypertension, diabetes, cardiovascular, even cerebrovascular morbidity was far, far high. Again, the authors have cautioned that they were retrospective and self-reported, so actually it may be slightly more prevalent. However, the one thing which we know is that you may not have COVID-19 if you have COPD, but if you do, the disease is going to be very severe. Severe infection was defined in these meta-analysis was acute respiratory failure or a requirement of ICU or both. And these are 4 references, meta-analysis of 6 studies. Odds ratio of severity of COVID-19 in COPD patients was 5.69. Another one found an odds ratio of developing severe disease of 4.38 in COPD patient. In Wuhan, they found that in older patient hospitalized, COPD was a predictor of death with a hazard ratio of 2.24. And in another large meta-analysis focused on comorbidities, the highest odds ratio for severe COVID-19 was for COPD. more than hypertension and other famous diseases. So yes, if you have COPD, you may be facing more problems if you have COVID-19 than others. And you may have higher risk of severe COVID-19 infection in patients with COPD. Why? Mainly because they are older, they have comorbidities, and they have poor immune responses, defenses, and impaired mucociliary clearance, and with which multiple infections can take their toll. However, again, the ACE2 receptors were found to be in the small airway epithelium of patients with COPD were found to be higher, with a significant inverse relationship between ACE2 gene expression and FEV1. So we know that if you are facing an obstructive airway disease, the symptoms can be so similar to if you have a COVID-19. Same cough, dyspnea, body aches, and fevers. Acute exacerbation of COPD, we know several viruses, several bacteria, and other allergens. Now we can easily include COVID-19 as one of the triggers. However, I have not seen any study which substantiates this thought. Again, as with asthma, no treatment change is recommended. In fact, it has been highly recommended very sensibly that good asthma control and good COPD control should fare you better through COVID-19 storm if you, otherwise we don't have it. There have been global drug shortages, especially inhalers in the COVID era because of multiple reasons. There have been shortages of ventilators for acute exacerbation patients who are admitted to the hospital, because most of the ventilators in big hospitals have been diverted to cater for the huge number of COVID cases. Avoidance of nebulization and NIV has posed problems, and I'll touch briefly a little later. Interestingly, this is something which I shared with my pulmonology colleague, that we obviously take histories from COVID-19 patients, moderate or severe cases. We've seen very few smokers. Is it the case? And some of my colleagues said that yes, they have been their observation as well. But these are some studies, 26 of individual studies and 8 meta-analysis. Was the risk of infection high in smokers? No study looked at that, or hospitalization. But severity, yes. Smoking was associated with increased severity of disease and death in hospitalized COVID-19 patients, as with COPD. So don't smoke and better control your COPD if you want to fare well. What about nebulization? From the early days, we have been warned that nebulization are aerosol generating procedures. So please do not use nebulizers because they will infect others. Interestingly, this UK recommendation has been there for several months, who claim that nebulization is not a viral droplet generating procedure. The droplets are from the machine, and nebulization is therefore safe to be used in COVID-19 patients. However, the other recommendations have been against using nebulization, and we can take our opinion from other colleagues what they say about it. So if you are advising nebulization in a at home settings, I think that's pretty safe. But I've been advocating and pleading my residents and colleagues, please, don't you know that inhalers, when used with spacers, have got almost the same penetration as nebulization? So why don't we revive the good old teaching? And we've been using this fairly commonly, inhalers with spacers. NIV has had the same aerosol generation problem as nebulization has. Bronchoscopy has almost halted with the COVID problem, and being an aerosol generating procedure, patients cough quite a lot during the procedure, and there has obviously there is a risk to the persons across them. It is not recommended as a primary. So obviously bronchoscopy can be either diagnostic or therapeutic. It's not recommended to diagnose COVID-19, although the highest sensitivity of COVID-19, more than the swab, the nasal swab or a sputum test, is with the bronchoalveolar lavage. However, because of its enormous tendency to infect others, this is not used as a diagnostic tool. Whenever used for even therapeutic purposes, full protection is recommended. Indications for bronchoscopy, the next slide, for COVID-19 suspected or confirmed cases. with strong suspect with negative swab in cases where you have to prove it. Patients on ventilator with atelectasis for mucus clearance. We were just talking this morning with Dr. Saima that we have seen that COVID-19 patients are, as a group, not mucus producers, fortunately, and very few cases of atelectasis have been seen, even in those who are on ventilator. So the usual reasons for bronchoscopy in COVID-19 patient, and I have already said that bronchoalveolar lavage fluid has the highest speed, but we don't use it for diagnostic purposes. So if you are faced with a reason to bronchoscope with due precautions, if it is a dire emergency, unfortunately there have been very few that we see as an obstructing mass, foreign body mucus plus, you've got to do it without waiting for the swab. And fortunately now with the advent of gene expert, the results can be had in 2 hours or 3 hours. But in other cases, you've got to have a negative COVID-19 test before you proceed to bronchoscopy. Pulmonary function test, again, spirometry. Patients cough a lot during the procedure, and hence we have drastically reduced our selection of cases whom we think that pulmonary function test will help. However, 6-minute walk test we quite frequently do. And I think the role of pulmonary function test will become more clear when we see the post-COVID situation, how badly has it affected the lungs. So my final 2-3 slides, managing respiratory disease in COVID era. Similar symptomatology, cough, dyspnea, fever, body ache. So we have a perplexion of whether it is COVID or is it just the exacerbation of asthma, COPD. Infections are common reasons for pulmonary consults. We have already asking questions. We always asking questions whether it's an exacerbation of obstructive disease or pneumonia or it's the COVID. And I don't think there's any other solution now with so many asymptomatic cases and rampant rise in COVID cases, other than just to, if you are in doubt, just do a COVID PCR and get away from the perplexion. However, we know then this false negative rate, so answer is not very easy. I think I'm just going to stop here. The other slide, but not the little old one. Thank you very much for the patient listening, and I'll be willing to answer any questions if there are any. And maybe other colleagues may like to share their experience. Thank you. Dr. Saima, Dr. Sabia, it's over to you.
Yeah.
Yes, thank you. Can you hear me now?
Yes, we can.
Yes.
Okay, great. Thank you. Well, thank you so much, Dr. Sohail, for a very interesting talk through how COVID-19 infection has influenced us as pulmonologists. And I think you're right that we're not seeing that many people with chronic respiratory disease, be it asthma, COPD, or interstitial lung disease, who are presenting with this. As you said, most people are diabetic or hypertensive. And so the real question is it underreporting of chronic respiratory disease in the first case, or is it some kind of immunoprotection? And maybe the immunologists who are in our audience could consider that, or help us work through that as a potential mechanism for some lung protection. And the other issue, I think, is also in the patient who is recovered from COVID. As we wait for questions, I wonder what your experience is in perhaps the contribution of immunology, or even otherwise, to this so-called fibrosis that occurs as soon as the patient is on a ventilator, or even subsequent to that. What's your experience, and what have you come across any papers regarding this?
One minute, sir.
Right. I don't have the answer to this question. I think it's early days. Only fairly recently we've started sending the patients home. But however, it is I think a common experience that many patients have not stopped coughing for several weeks and have been breathless, and the need for oxygen, the hypoxia, especially the exercise hypoxia, doesn't finish so soon. We may be seeing a plenty of pulmonary fibrosis post-COVID. And I think we should get the answer fairly quickly as to what to do early, because once the fibrosis has set in, there may be very little that we can do. I would like to hear if anybody else has any other experience on this.
Thank you,
Yes,
Simon. Yeah. So maybe, as you said, that the response in patients with asthma is really, very complex. As Dr. Suhail said very astonishingly, that the patients with allergic asthma, actually, they are less prone to have severe diseases as compared to the one without allergic asthma. And on the one hand, we see that in patients with COVID-19, there's an exaggerated immune response. So this is really very complex and need to be to do more research on it, because as we see that in the patients who have allergies, the immune response is actually skewed towards Th2 response. Whereas in patients with infections, then the immune response is actually skewed towards Th1 response. So maybe there's something over here that is actually benefiting the patients to having less severe or more severe, or vice versa in these kind of patients. But needs to be, to do some studies on these patients. That's my point of view.
And Dr. Sabia, I would be interested in your thoughts about delayed resolution of inflammation in patients, which may be predisposing them to ongoing symptoms. So when we in the COVID unit see patients who have perhaps come off the ventilator, they're weaning off their oxygen, they still have a lot of symptoms like Dr. Sohail has described. Do you think this connects in any way to the problems that we see in chronic inflammatory diseases, such as not even related to the pulmonary system, but perhaps Crohn's disease or inflammatory bowel disease, where you have a chronic inflammation that is causing kind of drip feed of symptoms?
So as we have seen so many studies that there is actually a cytokine storm. I mean, there's an upsurge of so many cytokines like tumor necrosis factor alpha, interleukin-1, and so many chemokines. So the studies are still ongoing. Maybe there's a problem in the what we say is the recruitment of the right kind of cells towards the site of infection, or they may be dysfunctional, like macrophages, which are the main cells which causes the resolution of the symptoms, the resolution of the inflammation, and they are themselves involved in the inflammatory process. So they probably for that period of time they are dysfunctional. So people are looking actually into it. They are actually looking into on the various biomarkers on the cells and the cytokine levels up and down, and probably very soon we'll have some kind of answer what's actually happening in those kind of patients who are having these kind of immune dysfunctions.
Thank you. Were there any other questions from the audience for Dr. Sohail?
I think they're enjoying the rain.
There's a question from Nagman that do you feel we are seeing lesser number of patients and with less severity? Dr. Suhail?
I would very much caution against being, on the comfort area. I don't think this is going to go away so easily. We've got plenty of work. The patients load in our hospitals, emergencies, and our wards are. When I say ours, I mean almost all the hospitals are really full. There have been lesser reporting in the recent weeks, but I don't know whether there is going to be another peak fairly soon, particularly the Eid al-Adha coming and so on.
We have one more question from Dr. Sabahat. What is your experience regarding allergic rhinitis and COVID-19?
Allergic rhinitis, the symptoms of rhinitis actually are in the first week or so. We mostly see the cases when they are bad and when they have got the lower respiratory tract infection. Rhinitis has been common. I cannot say from our experience, less than 50% patients do have rhinitis. Not very common, not more common than fever. But it's a fairly less troublesome symptom than obviously the hypoxia resulting from the lung damage. In the initial phase, in fact, COVID-19 looked exactly similar to virtually any viral flu. It's only when the lower respiratory tract gets infected when it poses problems. I am, by the way, neither an ENT specialist nor an immunologist, so I see very few cases of allergic rhinitis personally.
Okay, thank you. Any other thoughts from anybody else? In which case, I think we can thank Dr. Sohail once again for his presentation on immunology and COVID disease and our experiences in the context of immunology. Thank you everybody for your attendance today and your participation. And I will hand it back to Dr. Sabia for her closing remarks. Thank you.
Thank you, Dr. Sohail. Thank you so much. And thank you, Dr. Saima, for a very wonderful presentation and moderation. So now with this, this is the end of our second session of the ongoing webinar. And we will meet again on 24th with 24th of July. That is next Friday with some more interesting presentation. So just stay tuned and see you then. Allah Hafiz, bye-bye.